Dr. Jennifer Brown, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity entitled A Global Spotlight on CLL, Shifting Strategies and Optimizing Outcomes. Today's program is supported by an educational grant from Merck. Now, let me introduce the faculty. We have Dr. Paolo Ghia, Professor of Medical Oncology, Università Vita Salute San Raffaele, and Director of the Strategic Research Program on CLL, as well as Head of the B-cell neoplasia unit at Ospedale San Raffaele in Milano, Italy. I'm Jennifer Brown, MD, PhD, Director of the CLL Center and Institute Physician at Dana-Farber Cancer Institute, and the Worthington and Margaret Collette Professor of Medicine in the field of hematologic oncology at Harvard Medical School in Boston, Massachusetts. And we're joined also by Dr. Tom Munir, MBBS, PhD, Consultant Hematologist at the Leeds Teaching Hospitals NHS Trust in Leeds in the United Kingdom.
Hi.
Paolo, I'll continue with the learning objectives then. We'll be assessing testing strategies that may inform clinical decision-making in the management of CLL, utilize updated guidelines and evidence supporting the integration of targeted agent classes in CLL as single agents or as part of combination regimens, including continuous therapy, fixed duration options, and novel combinatorial regimens. And we should be able to evaluate recent clinical evidence on current and emerging therapeutic approaches that have been evaluated for the treatment of patients with relapsed refractory CLL and/or therapeutic intolerance. We'll continue with just a brief introductory slide on the global burden of CLL, which is illustrated here. We know that particularly in Europe, North America, rates of CLL are quite high, and that CLL has a much higher prevalence than incidence because fortunately patients do live a long time. And so we have substantial populations of patients living with CLL over extended periods who need a range of different treatments. So our first question, when do you use biomarker testing for patients with CLL, SLL? I do not use biomarker testing. I do it only at initial diagnosis, only at first progression, at initial diagnosis and first progression, or prior to any new treatment. So if everybody can answer that question, get us started. Okay, so 27% of people are not using biomarker testing at all, 20% at initial diagnosis, 13% at first progression, 33% at initial diagnosis and first progression, and then 7% prior to any new treatment. So, you know, that's a somewhat interesting result. I do it at initial diagnosis, first progression, and prior to any new treatment, especially because we do know over time sometimes there can be clonal evolution to higher risk markers. Tal, did you want to comment on your approach here?
So, yeah, I think primarily similar to your approach. I think in terms of initial diagnosis, the most useful test I find is IGH3 mutation test because that we need to do only once. But in terms of the other markers, it's very much a discussion with the patient as well, what they want to know in terms of the prognostic impact of the biomarkers. And if they do want to know everything, then I do that. But then at progression, definitely. And I think as we'll discuss later, I think it becomes important in terms of the era of targeted drugs that we do the biomarkers at progression so that will help us to inform how best to choose the therapy for our patients. So yes, I agree with all of that.
Right. It's a good point, though, that IGHV is stable over the entire disease course. So once done, you don't have to do it again, in contrast to karyotype, FISH, and mutational analysis, all of which can evolve. Now, we know that biomarker testing is not done as widely as it should be. These are some data from the United States, where, in fact, more than half of patients did not receive any biomarker testing at all. And in particular, when we're looking at the identification of patients with P53 aberrancies, such as deletion 17p or TP53, this is very important because those patients should not ever receive chemoimmunotherapy or chemotherapy anymore. And many of the patients were not identified so that they did actually receive that inappropriate therapy. Okay, now we have another case, a 62-year-old patient who presents with a leukocyte count of approximately 120,000, 80% of which is lymphocytes, hemoglobin level of 8.5, and platelet count of 85. Immunophenotyping confirms that he has CLL, which carries deletion 17p. Which of the following is the best choice of therapy for your patient with newly diagnosed CLL? And the choices are FCR, BR, continuous BTKI monotherapy, venetoclax obinutuzumab, venetoclax ibrutinib, or I'm not sure. So go ahead and vote there. Okay, so we have our 62-year-old patient who needs initial therapy for his deletion 17p deleted CLL. So no one voted for FCR, that's good. We did have 10% of people voting for BR though, which really is not a good choice at all because the 17p deletion means that BR has very poor activity. 30% for continuous BTKI monotherapy is a good answer. I think most of us would say that continuous BTKI monotherapy is probably the most standard approach to this high-risk patient population, although there are emerging data with venetoclax ibrutinib, and arguments can also be made on behalf of venetoclax obinutuzumab. But it looks like a lot of people were not sure, so we're going to show you the data and discuss the data. So I'm going to turn it over now to Dr. Munir, who I think is going to present some rounds of slides addressing how we think about this patient.
Thanks, Jennifer. So first of all, I will thanks for being part of the fantastic faculty. I will try to get through the data for the whole cohort, as well as looking at the individual disease group areas such as 17p deletion and IGHV mutation. So first study to talk about is Elevate-T, and this is now the 5-year follow-up for patients who had previously untreated CLL, and this trial was looking at acalabrutinib with or without obinutuzumab versus standard arm, which is chlorambucil obinutuzumab. And now we've got the 5-year follow-up on this study, clearly showing the acala arms doing better as compared to chlorambucil obinutuzumab. But the intriguing thing in this study is the addition of obinutuzumab to acalabrutinib. And now, as an exploratory analysis, the acala obinutuzumab had got a 5-year estimated PFS of 84% as compared to 72% with the acalabrutinib arm. We saw lower incidence of cardiovascular AEs such as AF, flutter, fibrillation, or hypertension, and the treatment discontinuation rates were lower in this study. So that now we've got a 5-year follow-up on continuous BTKI inhibitor therapy in this Elevate-TN study. The CEQUA study is interesting because this is looking at the second-generation BTK inhibitors and ibrutinib versus bendamustine rituximab, and this data has now been updated as well, where clearly we are seeing the benefit of continuous BTK inhibitor as compared to chemoimmunotherapy, which has been shown in multiple studies as well. At this time point, the median PFS for BR is reached, but not for zanubrutinib, again showing that the second generation BTK inhibitor therapy is well tolerated and preferable to be used as compared to chemoimmunotherapy in the patients who can tolerate bendamustine rituximab. But what about fixed duration therapy for frontline CLL? And now we've got CLL 14 data, which was updated at EHA. Now we've got 6-year follow-up. So this is venetoclax obinutuzumab versus chlorambucil obinutuzumab with a treatment period of 12 months with venetoclax. And with a median follow-up of 76.4 months, the estimated PFS at 6 years was 53.1%, with a median PFS of more than 6 years at 76.2 months, clearly in favor of venetoclax obinutuzumab. The other thing to talk about this study is that it is truly reflective of the CLL population we see. 60% unmutated IGHV patients and 12% patients with TP53 aberration. So with fixed duration therapy, we've now got a long follow-up on this study. What happened when we use ibrutinib in combination with venetoclax as a fixed duration approach? So this is ibrutinib run-in for 3 months, followed by 12 months of combination with ibrutinib and venetoclax. And now with a 4-year follow-up on this phase 2 Captivate study, we can see that we are starting to see a very good response in this group of patients. With all patients, the 4-year PFS rate is 79%. We have not reached a median there, but this group of patients, 56% have IGHV unmutated status, with 30% of the patients with TP53 aberration. I'll talk about it later in this presentation. What's happening with the patients who are unfit patients core and GLOW study? This was looking at the same combination in a phase 3 design versus chlorambucil obinutuzumab given for 6 months. And with this longer follow-up on this study, which is coming up to 4 years, again, the PFS was in favor of ibrutinib venetoclax. If you look at the overall survival data now, this is coming in favor of I+V, which is important to recognize that this is the combination which is showing an overall survival difference with some caveats. But interestingly, you can see that there were some deaths which happened early on with this combination, and then the curves crossed over. There were more deaths in the chlorambucil obinutuzumab arm in the follow-up, which were mostly infection-related. So if you look at the summary of studies on previously untreated CLL, in the ELEVATE-TN study, we are seeing the benefit of acalabrutinib with or without obinutuzumab. I've got the PFS and overall survival data there. The CEQUA study, again, showing the benefit there. And we've now got the fixed duration therapy with venetoclax obinutuzumab, which is showing an estimated PFS of 53% at 6 years, and then Captivate and GLOW data. I think the GLOW data is interestingly showing that there is an overall survival difference with the I+V combination as compared to chlorambucil obinutuzumab, but there is this caveat that that might not be the standard of therapy that we now use for our patients. But if you go into the nitty-gritty of the smaller subgroups, now we're talking about the 17p deleted or TP53 mutated patients, and some interesting findings there. This is again ELEVATE-TN. There are 23 patients in the acala arm and 25 patients in the acala-obin arm who had TP53 aberration. And the estimated PFS comes at 71% at 5-year follow-up. Interestingly, you're not seeing that benefit of adding obinutuzumab to this subgroup of patients, which we can talk about. But again, showing continuous BTKI inhibitor therapy providing benefit. In the CEQUA study, there was an arm for 17p deleted patients, and these patients had 17p deletion detected by FISH. I think the important thing with this study is this is 110 patients, actually. It was a large number of patients going into a clinical trial. And here you're again seeing an estimated PFS of 79.4% with an overall survival estimated at 89.5% with zanubrutinib as a continuous therapy. If we look at the IGHV mutation status in the same CEQUA study, if you look at the zanubrutinib arms, whether you have a mutated status or unmutated status, both group of patients were actually benefiting with continuous BTK inhibitor therapy. With the BR arm, you're clearly seeing the slip between the two arms, between the two groups, the unmutated and mutated group. But it is clear from this follow-up now that both mutated and unmutated group are benefiting with continuous BTK inhibitor therapy as compared to bendamustine rituximab on this follow-up. If you look at the CLL14 data, and this is quite interesting data, where if you group the patients based on the IGHV and TP53 status, so group with the flat blue line mutated IGHV and TP53 deleted mutated patients, very small number of patients. These patients are actually doing pretty well. But the patients who have got unmutated IGHV stated and TP53 deletion mutation, those are the patients which are falling off the curve in CLL14. So clearly, with fixed duration therapy, we are seeing some delineation depending on the genomic profile of the CLL. Again, in Captivate study, if you look at the TP53 deletion or mutated patients, the 4-year PFS rate is now 63%. For unmutated IGHV patients, it's 73%. And for all untreated patients, you're seeing that at 79%. So clearly, again, with the ibrutinib and venetoclax, we are starting to see that these subgroups will evolve, which is different to what we're seeing with continuous BTK inhibitor therapy. Then talking about the Ghia study, the CLL13 study, this is the group of patients who could have chemoimmunotherapy in the form of FCR if they were less than 65 years of age, or BR if they were above 65 years of age. And then there are 3 experimental arms looking at venetoclax-based therapy with rituximab or obinutuzumab, or you can have venetoclax with obinutuzumab with ibrutinib if MRD positive for 12 to 36 months. And they did a number of analyses, including chromosome analysis as well as CBA at diagnosis and at progression as well. And in terms of the endpoints, there were 2 endpoints. One was the MRD endpoint, the other co-primary endpoint was PFS. And clearly the venetoclax obinutuzumab containing arms were doing better as compared to chemoimmunotherapy. Interestingly, when you compare the venetoclax rituximab versus chemoimmunotherapy arm, there is no statistical difference in terms of PFS at this shorter follow-up. And when you go into the nitty-gritty of the mutational status, clearly in terms of the chemoimmunotherapy, those are the black lines in terms of the blue lines in terms of the chemoimmunotherapy arm. You could see the clear split between the mutated and unmutated group. But at this follow-up, with a shorter follow-up on the Ghia study, there was no difference in the GIF arm in the unmutated or mutated group. And same can be said true about the venetoclax obinutuzumab arm. The interesting thing in this curve is the VENAR arm, where the mutated group appears to be not doing as well that I would have expected, but overall clearly suggesting that we need longer follow-up on this study at this moment in time.
Tal, maybe I stop you with a question so that you already provided a lot of information, so maybe we can have a short discussion. So you show that indeed there is no immunochemotherapy that can benefit neither the unmutated patient, but in particular also now we have evidence that also mutated patients do not benefit from chlorambucil-based, bendamustine-based, and you didn't show, but also FCR-based, fludarabine-based treatment. So how now the unmutated patient, we know that the mutated patient, we know that they do not benefit from immunochemotherapy. How would you treat them if you have to choose for fit, unfit patient based on the fact that they are carrying mutated patient? What is your preferred, or how would you choose a novel treatment for the mutated patient?
So I think, Paolo, that's a very good question. And I think it's become difficult with all the data that we're seeing now. We clearly, as with the zanubrutinib, bendamustine, rituximab data in the sequel, now the mutated IGHV group patients are benefiting. We know from the ECOG 1912 study with the longer follow-up, the mutated patients are benefiting from continuous BTK inhibitor therapy. But in terms of the fixed duration therapy, the venetoclax obinutuzumab patients treated, mutated IGHV patients treated with that combination appear to be doing very well. So if I have got an option to treat those patients, I have got multiple options now, which would be good for the patient, and the patient choice becomes important. But if I have to choose a fixed duration therapy, then venetoclax obinutuzumab is my preferred choice at this moment in time, because clearly the data for that group of patients is very good.
And maybe I involve also Jennifer. Would you still distinguish between unfit and fit patients when they are carrying mutated immunoglobulin genes? So, or there is one treatment for all? How would you do?
No, that's probably fair. I think that the mutated IGVH patients particularly benefit from fixed duration regimens, because we know that if they get to undetectable MRD, they can have very prolonged remissions. And so that would favor the venetoclax obinutuzumab. And in general, we have data now in both fit patients from Ghia and unfit patients from CLL14 that venetoclax obinutuzumab is a very effective regimen. So I'm not sure one does need to distinguish a priori, although I will say that I find that older patients may be less inclined to want to come in for all the visits and infusions that are required for the fixed duration therapy. And so it may be that their preference overrides the bias in favor of time-limited therapy, because they'll do very well with the continuous therapy as well for less effort, potentially.
Yes, that's a very good point. And indeed, it's happening several times, I think, in real life. The patient may decide really based on the number of visits they are required. And to follow up on that, actually, there is a question here from our audience. Because you mentioned about continuous treatment versus fixed duration treatment. So Tal, how do you feel about drug holidays for patients who are having difficulty tolerating BTK inhibitor therapy? Is this something that you do? Is it something that is foreseeable that we will be doing in the future? You have a study ongoing, so.
Yeah, so we are looking at that question in our UK study, FLAIR study. We treated patients with continuous ibrutinib therapy for at least 6 years. And what we're finding in some of those patients is that you get very deep responses, not MRD negative responses, but at that point, the disease bulk is extremely low. So we have got a study at the moment called STATIC, where we are randomizing half of the patients to receive intermittent therapy, and the other half of the patients will continue the therapy. And we're looking at the point mutations in the BTK, but also looking at the tolerability of this approach. The other issue is whether we really need to give continuous therapy to these patients, because they accumulate toxicity over time. And with the best will in the world, all the new BTK inhibitors are going to be looking like to be less toxic. But I think the cardiac signal will continue. And if our patients are in deeper remission, whether that intermittent approach is nearly as good as continuous approach is a question that needs to be answered in a setting of a clinical trial. So yeah, I'm all for drug holidays, especially if the patient has been on the drug for a long time and they are in deep remission. But in the trial, we are going to restart therapy at point where there is some sign of clinical progression, and then we'll see what happens when we re-expose the patient to the molecule again.
Yeah, indeed. I mean, we all agree that we are looking forward to the moment when we can give drug holiday. We don't really know after how long, and in particular, what we are supposed to do upon relapse or upon progression. So that's a question that, as you said, have to be answered in clinical trials. So maybe now we can move to the MRD, which is probably, it might be one solution for drug holidays. And so please, Tal.
So I think I'll hand over to Jennifer. I think Jennifer will take over.
Okay, so as we know, minimal residual disease is a way that we measure depth of remission, with the classic traditional method being to a level of 10 to the -4 or 1 in 10,000 cells. typically by flow cytometry. But sometimes it can get down as low as 10 to the minus fifth, even with flow cytometry. And then with next generation sequencing, we can potentially get as low as 10 to the minus sixth. So many of those methods are being studied along with the standard flow cytometry method. And we know that with time-limited regimens, venetoclax regimens in particular, depth of MRD correlates strongly with progression-free survival and overall survival also, in fact. So we can see CLL 14 on the left, the patients with detectable MRD at the above the 10 to the minus 4 level are doing particularly poorly on PFS. But it also looks like there might be starting to be a difference for those who are at the between the 10 to the minus 4 and 10 to the minus 5 level as well, which we'll see with additional time. And then in Captivate on the right, again, treatment naive with venetoclax ibrutinib, we can see that patients with detectable MRD are again relapsing sooner once therapy is stopped, as we would expect. So the VISION or HOVON trial actually used MRD guidance to determine how patients would be managed. This is a relapse setting trial, combination of ibrutinib venetoclax for 15 months. And then patients who had MRD undetectability were randomized between observation or continuing ibrutinib until progression. And then those who are on observation can potentially reinitiate treatment if they have CLL progression or are established to have continuous MRD relapse. And then those patients who are MRD positive just remained on ibrutinib. So we can see that on the right panel, after 15 cycles of venetoclax ibrutinib, about 32% of patients achieved undetectable MRD and it lasted partial response. And again, this is a relapse setting trial, so the rates of achieving undetectable MRD are lower than we see in the frontline trials. And this trial was just updated at EHA with substantially longer follow-up. And we can see that in arm A, the patients on ibrutinib until progression or toxicity had a 54% rate of discontinuation, 25% due to toxicity, whereas those who were able to stop and be observed and potentially restart had a much lower rate of discontinuation and low rate of toxicity. And interestingly, the PFS for those who were observed was 81% at month 51 versus those continuing on ibrutinib was 92%. So both very good outcomes. But what always interests me the most is that actually the patients who did not achieve undetectable MRD, who were not randomized, actually had the lowest PFS at 75%, suggesting again that response to therapy as measured by depth of remission with undetectable MRD may be demonstrating something that we can't otherwise measure as yet about the biology of the disease that does predict outcome. The BOPIN trial also used MRD guidance to determine the duration of therapy. This is a frontline trial, a triple drug regimen of the covalent BTK inhibitor zanubrutinib with obinutuzumab and venetoclax. And the obinutuzumab and zanubrutinib started together at cycle 1 and venetoclax ramped up at cycle 3. And then patients were assessed for MRD serially over time. And once it was achieved and confirmed, patients were able to discontinue therapy. So the majority actually discontinued at about cycle 9. So the duration of therapy was substantially shorter than in many of our other trials. You can see the progression-free survival is quite good for all 50 patients. And the regimen was well tolerated with no additional safety signals and high rates of undetectable MRD. Now, in this study, they actually did a measure of the rate of drop of MRD that they called Delta MRD 400. And so the patients who achieved a more rapid drop, more rapidly approached MRD were able to stop therapy a little bit sooner and then also had a more prolonged duration of undetectable MRD than those who took a longer time for their disease to decline. And similar findings have also emerged from the from the Clarity trial in the UK, where again, the rapidity of response and approaching MRD was associated with the durability over time.
So maybe, Jennifer, before we get to the case, we receive a couple of questions. And one is really appropriate to your presentation, because he's asking, you mentioned about 10 to the minus 4, but he's asking what is the MRD cutoff that we should be using. So is that the definite answer, or how do you see?
Well, you know, at the moment, I think 10 to the minus 4 is probably what we should be using for our prognostic purposes. We have the largest amount of data for that. You know, if we're going to start to talk about cure and complete disease eradication, though, we probably want to strive for the deepest level of MRD that we can measure, which is potentially 10 to the minus 6th. We don't have a lot of data demonstrating that outcomes, if you actually get to 10 to the minus 6th, are better than a 10 to the minus 4 as yet, though. Although I think we'll probably start to accumulate more of that data over time, since now in most studies we're doing multiple approaches to MRD. But, you know, the most important question also to ask is, if you do measure MRD and at a higher depth, what are you doing with the information, right? We're really using it prognostically now rather than to change therapy. There's no evidence that if someone's still MRD positive, you should give them a new therapy to try to get to undetectable MRD. We don't know that that actually changes the biology as yet, right? We need more trials, and I think that we're all interested in trying to pursue trials of that sort where we're using MRD for therapeutic decision making.
No, and in fact, I mean, most of the trials, or at least those with a longer follow-up, have used MRD just to assess the quality of the response, but they were not really MRD-driven studies. So now, as you've shown, with the BOVEN and VISION, new studies are starting indeed with MRD as an endpoint, a decisional endpoint, so that we probably in the future can answer these questions. The other important discussion about the MRD level cutoff, and maybe Tal can add something based on the work that has been done in Leeds, is that it might help different level in the peripheral blood, it might help to predict the negativity, let's say, in the bone marrow. So that could be an added value to go lower in the peripheral blood. What do you say, Tal?
Yeah, it's MRD is, as Jennifer said, in most of the trials, MRD is an afterthought, really. Whereas what Jennifer has shown in the HO1 study, the MRD-driven approach is the proactive approach, how to use MRD to dictate therapy, and that is a trial question that needs to be optimized. And I think the main problem how to use the approach is the main question about how to use MRD and when to analyze and how to analyze it as well. So our experience with flow cytometry is that we can standardize it quite easily, and multiple labs can do it. There could be a standardized approach, and that helps. But then in terms of regulation, we need to go one log deeper to where we are finding the results. So if you're looking at 10⁻⁴, you really need to make sure that your MRD is giving you a one log deeper answer, like 10⁻⁵. And then we go to 10⁻⁶, the flow just is very, very unreliable at that point. So we are limited by what we can do, and that's where the clonoSEQ comes into play. In terms of the compartment effect, that is very important, because the monoclonal antibodies will have a preferential clearance of MRD, like obinutuzumab is extremely good as clearing the peripheral blood. Same is true about Campath. It clears the peripheral blood and bone marrow well, but then the nodal responses are not that great. But then when you go to I+V combination, the log depletion is not that different between the bone marrow and the peripheral blood, whereas you see a differential response with Veno. So it does make a difference which compartment are you using to analyze MRD. And I think peripheral blood in most of the data that we've seen up till now with the new combination appear to be reasonably well correlated now. So 0.3 difference between I+V and 0.7 difference between Ven+O, if I'm absolutely pedantic about it.
Okay, thank you, Tal. Actually, there is another question that really is addressing your presentation on Ghia, and the colleague here from the audience, he's also aware about the safety issue with the triplet. So he's asking, how do you balance efficacy and safety between triplet and doublet therapies? Also with the bovine, of course, so it's another triplet therapy.
I think that's the biggest question really in terms of which patients we should be using triplets and which patients we should be using doublets. And even if you look at the I+V combination in GLOW, in elderly population, only 77% of the patient finished therapy, whereas for the younger population, it was 93%. And similar results were seen with ven plus O. So not even every person can tolerate a doublet, and then we go up to the triplets. It becomes very, very biased. And if we looked at the data from with Jennifer Wojcik presented at ASCO with IO versus IVO, it's clear that toxicity is a major question when we are going to use triplets. So I think the triplets, if I was going to use it, my approach would be very much MRD-driven approach in those patients. Try to limit the number of the duration of therapy using that approach. But I think at the moment, doublets are most probably the standard of care, and I'm still to be convinced that triplets will be used for majority of the patients. They might be good for MRD-driven approach, in my view, at this moment in time.
Yeah, or to consolidate. And now we have a question that is right for Jennifer. And so are BTK inhibitors interchangeable for patients without cardiac contraindications? So really this indicates, is there any issue in patients without cardiac complications, or we should care only in patients elderly and with already cardiac comorbidities?
I think it definitely still matters. The incidence of ventricular arrhythmias and sudden death, for example, is low enough that we really don't properly understand the risk factors. In FLAIR, of course, it was associated with male gender and hypertension, but in our series, when we had first described it, we had some young, fit men who had no cardiac disease who had sudden death with ibrutinib. And so my personal feeling is that the toxicities of ibrutinib are potentially significant even for the younger patients without cardiac comorbidities. And when we have head-to-head trials, acalabrutinib versus ibrutinib, zanubrutinib versus ibrutinib, that demonstrate improved cardiac safety as well as improved safety in general, I don't see a reason to be using ibrutinib.
Okay, so now maybe we go to the case. So your 71-year-old patient received the first-line venetoclax obinutuzumab, and then second-line ibrutinib monotherapy, continuous therapy for CLL, unmutated immunoglobulin intact p53, so no deletion 17p, no mutation in p53 gene. And now comes to you after 3 years of continuous ibrutinib therapy with increasing circulating lymphocyte count and decreasing hemoglobin levels, so showing signs of progression and relapse. So what is the best choice of therapy for your patient when you decide to switch to a third-line therapy? So you go back to immunochemotherapy, bendamustine plus rituximab, or zanubrutinib monotherapy, so continuous BTK inhibitors. Another one, second generation, idelalisib monotherapy, so you change a little bit the mechanism of action, PI3 kinase delta inhibitors, or clinical trials with a non-covalent BTK inhibitor, or I'm not sure. So we have a few responses. And we have the answer. So no, this is really amazing. So everybody would go for the non-covalent BTK inhibitor. So there is a lot of expectation. Hopefully, some of the colleagues in the audience had also the chance to have experience with these new molecules. But 2/3 are still saying not sure, and this is probably the right answer, because in real life, in daily life, we have really no options, or very limited options in the third line. So what we call the double exposed, double refractory, double resistant. We will hear from Jennifer in a second about the patient who already received a BTK inhibitor and venetoclax, and therefore, what shall we do with them? So please, Jennifer, take over and let us know about the future.
Okay, thanks, Paolo. So just to remind everyone, 16 to 23% of patients on continuous BTKI therapy from the early trials developed resistance. This mostly comes from the studies with ibrutinib, although there are a couple studies with acalabrutinib as well now. The most common alteration is C481S, and then sometimes there are other C481, other amino acids, including R, that are in the ATP binding site and the binding site where the covalent inhibitors bind. And so these mutations prevent attachment of first or second generation covalent BTK inhibitors. And the resistance is associated particularly with indefinite treatment, most common in pre-treated patients, relapsed patients, or patients with p53 abnormalities. So here we have the covalent inhibitors on the right, ibrutinib, acalabrutinib, and zanubrutinib with their kinome profiles. And we can see that ibrutinib is the least specific, followed by zanubrutinib and acalabrutinib. These three are all covalent and irreversible. Now, but the non-covalent BTK inhibitors do not require a covalent attachment to residue 481. They can still be highly selective, but their binding is reversible. And they can act on both wild type and C481 mutated BTK. And so we have fenebrutinib, nemtabrutinib, and pirtobrutinib listed there as non-covalent and reversible, with nemtabrutinib and pirtobrutinib being the ones that have advanced in clinical trials in B-cell malignancies. Here we have the kinome profile and structures for pirtobrutinib and nemtabrutinib. You can see pirtobrutinib is really quite specific for BTK on the kinome profile, whereas nemtabrutinib has a broader profile, including other targets that might also have activity in this setting, for example, MEK. So pirtobrutinib is approved now in the United States for relapsed or refractory mantle cell lymphoma after at least 2 lines of systemic therapy, including prior BTK inhibitor. It will inhibit both wild type and C481 mutant BTK with equal low nanomolar potency in vitro models and CLL cells. And the steady state plasma exposure achieved in the phase 1 study corresponds to 96% BTK target inhibition, an estimated pirtobrutinib BTK binding complex half-life of about 2 hours. It's also hypothesized that in contrast to covalent BTKI, as shown in A there, which lead to an open conformation, that pirtobrutinib may stabilize BTK in a closed inactive conformation, and this blocks the access for upstream kinases to phosphorylate Y551. And this may then inhibit scaffolding interactions that are part of kinase-independent BTK signaling. So pirtobrutinib has been studied in a large phase 1/2 Bruin study. This is open-label pirtobrutinib monotherapy with several hundred CLL patients now, median of 3 prior therapies, about a quarter with deletion 17p, 30% p53 mutated. So overall, about half had p53 aberrancy, and 88% had unmutated IGHV. The overall response rate it increases over time from about 65% at 6 months up to about 80% as you get out to 12 months. And the median PFS in covalent BTK inhibitor pretreated CLL SLL, this is the population with 3 prior therapies, is about 19 months. If you look at patients treated both with covalent BTK inhibitor and BCL2 inhibitor, it's a little bit shorter at 16 months. And they had a median of 5 prior therapies. The drug is actually extremely well tolerated, with neutropenia being the only really appreciable grade 3/4 event, and even that relatively low. So there have been a number of reports recently about resistance to pirtobrutinib being associated with non-C481 BTK mutations. And recently, I had the opportunity to present data from 49 patients evaluated as part of the Bruin trial in the setting of acquired resistance with data available, NGS targeted panel data available from baseline and from time of progression. And so 71% of patients in that analysis had at least one acquired mutation at progression. 55% of them had an acquired BTK mutation. So that means there were actually 29% that had no mutation detected in the targeted panel, suggesting an alternative mechanism of resistance that we're not sure what it is yet. But the BTK mutations were predominantly T474, the so-called gatekeeper mutation, which you can see in both the panel at the right and at the bottom. And then this was followed second most commonly by the kinase impaired L528W mutation. And you can see how this contrasts from baseline where C481S is the predominant. There were only a couple C481 mutations that occurred in the acquired setting, and they were not S, they were other amino acids that are associated with lack of kinase activity. So in short, on pirtobrutinib, we see a decline in C481S mutations, and then a rise in T474 L528W mutations. Now, what was of interest, the cutoff of the assay was about 5%, a variant allele frequency of 5%. So it was of interest to go back and look at the baseline samples and see if these mutations could be detected at lower levels. And in fact, this was the case in 24% of them, that they were pre-existing at low variant allele frequencies of just 1 to 3%. This is illustrated in the upper left panel, where you can see a T474 mutation was present at baseline below the level of detection, but then by cycle 9 had risen to 76%. And this also was the case with L528W mutations that you can see on the right. And it's important to note that patients with these low VAF resistance mutations at baseline still had similar responses to pirtobrutinib with similar time on pirtobrutinib. Note about nemtabrutinib. So nemtabrutinib is also a non-covalent inhibitor. It binds to the kinase domain's ATP binding region and competes with ATP, forms hydrogen bonds with 2 backbone residues. And the solvent-exposed polar tetrahydropyran methanol side chain facilitates extensive hydrogen bonding. So binding of nemtabrutinib is not dependent on C481, so mutations at this residue should not impact binding, similar to what we've seen with pirtobrutinib. So nemtabrutinib has been studied in the Bellwave phase 1/2 open label study. Cohort A for patients with a covalent BTK inhibitor prior treatment and a C481 mutation. Cohort B included patients intolerant to BTK inhibitor without a C481 mutation. The recommended dose was 65 milligrams twice daily for nemtabrutinib. And you can see the patient population on the right, median of 4 prior regimens, 95% of whom had had prior BTK inhibitor therapy. 63% carry C481S, 32% TP53. Now, in terms of treatment-related adverse events, about 40% of the patients did have grade 3 or 4 adverse events, 17% neutropenia, but hypertension was seen in 30% and arthralgia in 20%, which again, those are side effects not uncommon in BTK inhibitors as a class. So here we can see the progression-free survival for cohort A with the C481 mutation, as well as cohort B without it. And the median PFS is estimated at 26.3 months for the both BTK and BCL2 inhibitor are having a somewhat shorter median PFS, as are the 17p deleted patients. Duration of response, the median was 24.4 months in the overall cohort. And again, in the subgroups, here actually median duration of response for patients with prior BTK and BCL2 inhibitor is 26 months. So in terms of therapy sequencing, patients will start on a covalent BTK inhibitor, and this could be ibrutinib, acalabrutinib, or zanubrutinib. Although, as I said earlier, I think we increasingly should move toward second-generation covalent inhibitors, given that they have proven to be less toxic in head-to-head trials versus ibrutinib. And then if patients develop resistance on those drugs, most commonly with a C481 mutation, they can be treated with nemtabrutinib or pirtobrutinib. Now, there's been some speculation lately that there are reports of the L528W mutation that causes resistance to pirtobrutinib in patients treated with zanubrutinib. It's also seen in patients treated with ibrutinib. And the question is, it might be a little bit more common with zanubrutinib. And so what we don't know is, should this be excluding patients from treatment with pirtobrutinib, which personally I do not believe so based on the level of data that we have at the moment. And we need a better sense of how frequent the L528 mutation is as a mechanism of resistance on zanubrutinib compared to ibrutinib, for example. And then I just showed you data that even if you had a pre-existing mutation at a low VAF, you could still respond well to pirtobrutinib. I would also note that the T474 gatekeeper mutation that is also associated with the resistance to pirtobrutinib is sometimes increasingly seen in acalabrutinib resistance. And so then the same question could come up there. Now, for patients who are intolerant to covalent BTK inhibitors, if they were on ibrutinib, we know that acalabrutinib or zanubrutinib is tolerated in patients who stop ibrutinib for intolerance. And then nemtabrutinib or pirtobrutinib are also options, as they also enrolled and studied this patient population successfully. If you've been on acalabrutinib, then your options would be zanubrutinib or nemtabrutinib or pirtobrutinib. And zanubrutinib, we would probably just go to the nemtabrutinib or pirtobrutinib in terms of intolerance. Okay.
So, thank you very much, Jennifer. And here, as you are showing, please continue ask questions. But I have to say that we are already receiving questions, and one is indeed very appropriate for your last slide, meaning that you showed what to do after one inhibitor, maybe another one, and then there is some among in our audience that is asking. Do you think there is a benefit in rotating BTK inhibitors? So is even he or she is even planning or having the idea to use even a third line BTK inhibitor, maybe the same one that you used initially. So what do you think about rotating a BTK inhibitor?
Well, I wouldn't do it in the absence of progression or intolerance. I'll say that, right? The other comment I might make is, so we do see that with pirtobrutinib, the C481 mutations go down substantially. So they're selected against, right? So that means that in theory, if you lose that resistance mutation, maybe you could go back and use ibrutinib again. But 474 make it, in our hands in vitro, it's sensitive to ibrutinib, although it may be not as sensitive to ibrutinib as BTK without 474. So, I suppose one could consider trying it, but overall, the more heavily pretreated you get, the less likely you are to respond to the same mechanism. And there are also mechanisms of resistance going on that we don't fully understand, and they may be going on concurrently with the BTK mutations, especially when you have relatively low allele frequency BTK mutations. So, I think we can consider that as we understand more about the mechanisms of resistance, but it would still be fairly exploratory at the moment.
Yeah, so it's a very attractive possibility, and definitely I'm sure that we will be seeing also studies addressing this question, because the idea that the clones are shaped by the different drugs, and so that refractory cases can become again responsive, it's very attractive. It would be very useful for patients, but I think we still need data. And there is probably too much enthusiasm on the mutation story. We don't really know how this really impacts in real life and in the clinical setting. And at the moment, maybe we can even say that there is really no indication even to study or to analyze in the clinical setting the presence or absence of mutation, because at the end is the clinical progression what is really addressing, what is really suggesting the switch to another molecule or the start of a different drug. So Tal, here I have instead another question, which is probably a $1 million question. What differences do you anticipate between nemtabrutinib and pirtobrutinib in terms of patient selection? Do you already see any light at the end of the tunnel?
I think that would be the next, these are two drugs which are effective in patients with double refractory CLL. If we are going to put a label on those CLL patients, and the good news is that both drugs are effective. I think in terms of the toxicity profile, that is slightly different at this moment in time. The way the kinomes are being blocked by these molecules is different. I think they are both a welcome addition to our patients who are in that boat. And I think we will see more of them, because we are seeing, we are using these targeted drugs much early on in our patient's journey. And we will be asking these questions in the relapsed refractory setting, how best to transit these patients from one to another. But I think at the moment, the data is so scanty that it is very difficult to envisage which patient will benefit more from one as compared to another, and whether a switch is possible, or same thing as what we did with covalent BTK inhibitors, moving from ibrutinib to acala or zanubrutinib. I think the same questions will arise between the non-covalent BTK inhibitors. Certainly, it also will come down to physician preference as well. Some people would have used more Perto as compared to nemtabrutinib, and other people would have used more nemtabrutinib. So it will all come down to that. At the end of the day, we do have option now to treat our patient with an effective drug. I think one of the main questions really would be that as we use these molecules early on in the therapy, how the switch will happen between the non-covalent to covalent, and whether we will lose effectiveness in that scenario. We don't have the answers to those questions at this moment in time.
No, in fact, as usual, as we always say, we need more follow-up. We really need to have solid data. At the moment, we are still in the realm of impressions. They are both giving very good impressions, but the numbers are limited. And in particular, as you mentioned, these patients are not only refractory to BTK and BCL2 inhibitors, but they also received many other lines of drugs before. So the picture is indeed confusing. So we might really need to really have a clear picture with patients maybe only failing 2 lines of therapy and see what really happens. With that, we are already approaching the end of our event today. So as usual, when the discussion is interesting with such an important faculty, the time flies. And I just want to make a very quick summary of what you heard so far. So again, as I just said, we need longer follow-up, and indeed we have longer follow-up for BTK-based combination therapy in CLL, in particular combination between BTKI and BCL2 inhibitors. Fixed duration is probably the future. We all agree, or probably where we are aiming at. We will try and use all a fixed duration in every patient. Of course, again, reminding always about the balance between safety and efficacy. We also know that immunoglobulin status MP53 are relevant. Patients should be tested even in the era of novel therapies, because they might help choose between fixed duration and continuous therapy. MRD therapy, MRD-driven therapy will be the future somehow, because maybe it will help us to achieve the right efficacy by reducing toxicity, by reducing the time of exposure to the drugs. And we heard also from Jennifer the story of mutations arising, resistance mutations arising to the BTK inhibitors, and maybe the interesting scenario where one could even rotate previously used BTK inhibitors, but this is again the future, and we have to see how the mutation of BTK will be incorporated in the clinical management of our patient. Non-covalent are, of course, the future, because this is the third generation. We will see if they will be moving to earlier lines, but definitely are already in our reality, because they can be very effective in treating patients who have been double exposed and are double refractory. And with that, I just remind you the SMART goals of this event: specific, measurable, attainable, relevant, and timely goals. Clinicians should ensure that all patients receive the biomarker testing for immunoglobulin, immunoglobulin genes, NP53 aberrations, deletion 17p by FISH, p53 mutations. Clinicians should use the whole spectrum of therapies that we have: monotherapy, combinations between BCL2 inhibitors and anti-CD20 antibodies, and combination nowadays more innovative, let's say, between BTK inhibitors and BCL2 inhibitors, though always reminding, as Tal mentioned, also the safety of the patient. We have to discuss much more with patients, in particular discussing the value of MRD and what to do when patients achieve deep responses, and the issues about stopping therapy, because indeed at the moment we don't have enough data to confirm that this is the approach where we have to go, and more studies in the future will be needed. And that remains the closing for all of us. Clinical trial participation should be encouraged for our patients, not only in third line, not only for patients at the end of their journey, but also already at the beginning, because the cure for CLL has still to be achieved. So we need to increase our knowledge thanks to the clinical trial. So with that, I thank the whole faculty. I thank the patients who have helped us to have so many new results and evidence. And with that, I want to remind you that if you want to receive CME credit, you have to complete the post-test and evaluation online, and you will be able to download and print your certificate immediately upon completion. With that, thank you again, Tal, thank you, Jennifer, and thank you all for being with us.